welcome to the next presenter session on our conference schedule. And we are extremely honored, and I should say thanks mostly to DY for initiating my communication with Professor Huali Wang. Huali Wang is probably the leading figure in China today in terms of dementia care, and her work throughout her career has established the role of practitioners in promoting intervention and prevention of neurodegenerative disease within Greater China, which of course includes the Greater Bay Area. To formally introduce Professor Wang, I would say the following. Professor Huali Wang is the Chair, Clinical Research Division and Associate Director, Beijing Municipal Key Laboratory for Translational Research on Diagnosis and Treatment of Dementia. She is also the Associate Director, Dementia Care and Research Center, Peking University, Beida Institute of Mental Health. Professor Wang has been closely involved in and served as one of the founding members and Secretary General of the Chinese Interest Group of Chinese Society for Psychiatry, an IPA affiliate. Professor Wang is a practicing geriatric psychiatrist and a leader in her field in China. Professor Wang's major contributions in the field include research on dementia and late life dementia, teaching and lecturing to develop the subspecialty of geriatric psychiatry in Greater China, capacity building, including educating primary physicians and young psychiatrists and researchers, and policy advocacy for aging and mental health. Professor Wang launched the first dementia caregiver support group in Greater China and is currently a leader in dementia care training for both the community-based family caregiver as well as staff in nursing homes. And on a personal level, I would like to just remark that I have worked in Beijing since 1990, visiting there at Beida, in fact, and began to work in neuropsychology. And I've become very aware over the past 30 years of the work on aging, mostly in the field of neuropsychology, but specifically in the field of speech and communication difficulties, which we have observed over the past 30 years has grown dramatically in prevalence. And I must say that engaging colleagues from Peking University is a great privilege because the position of Peking University and the medical school is superior in our region. So without further ado, I will ask the team in Hong Kong to begin the presentation, and Professor Wang, who you see, will be available for Q&A at the end of the presentation. Thank you.
Thank you, Professor Vicky. It's my great honor to be invited to this webinar. I'm very glad to join this, and I would be happy to share my slides with the audience. I'm so honored to give a talk about dementia care service and policy in China. Following the talk by DY, I will specifically talk about the activities happening in China and also highlight what kind of policy we have developed in the past years that can help us to promote the quality of dementia care in China. So my talk will consist of 4 parts. I would like to introduce the concept of providing continuous dementia care for the people living with dementia and how we can provide the try to promote dementia care in community and in residential services. And in the last part, I will highlight the documents related to the policy to improve dementia care and also for health promotion in aging. According to the latest consensus, the census data, people aged over 60 years have exceeded 18% of the whole population. The people aged 60 and 60 above exceed 13% of the whole population. So we could easily tell that China has been an aging country. So within this challenge of aging, one of the greatest challenges is how we can manage the people living with dementia, because dementia is a type of diseases that the risk increase with age. So while currently, when we're talking about how to promote healthy aging, we definitely have to identify the solutions for dementia care. Currently, the prevalence of dementia has exceeded 10 million of the whole population in China. So as I mentioned, that dementia is a great challenge in our society. But in contrast, people understand dementia not in a good level. DY just mentioned that there is a strong stigma against dementia. But here, I would like to focus that people know little about dementia. Although a lot of educational programs, videos, films have been broadcast in the society, people know what kind of signs of dementia is, but they don't know where they can go to seek support, especially for timely diagnosis and also scientifically or evidence-based care. According to one survey conducted in China in urban areas, we found that people know memory loss is one of the key symptoms of dementia. People know that for people living with dementia, they have to go somewhere for treatment, but they don't know dementia is a type of diseases. About 50% of the study participants still consider that dementia might be one of the normal aging process. Unfortunately, during the survey, we found that only 22% of the participants understand where they can go to seek optimal care for dementia, because they don't know the nature of the disease, so they don't know where they can go. And also in another survey conducted in memory clinics in the whole country, we conducted that survey in 28 memory clinics in big cities. We found that during the year of 2013, only 1/3 of the participants or the patients can be referred to memory clinics within 1 year. So it seems that the care or the pathway for seeking diagnosis has been detoured. So people has a significant delay in seeking diagnosis. But fortunately, last year, according to a national survey in about 1,000 participants in the country, the access to memory clinic has been improved. So in the big cities, people get access to memory clinic much earlier than before, but that data was only conducted in big cities. So it is not quite a representative of the whole country situation. So we are still be challenged by low literacy of dementia, but also be challenged by the significant delay in seeking diagnosis in our country. In order to improve timely diagnosis and try to seek optimal care for people living with dementia, how we can provide a solution in the society. We usually understand that to improve dementia care, we have to develop the person-centered care. Of course, technically, we understand that we have to build effective communication with the person. We have to try to seek a certain type of approach to calm the people living with dementia, to help them to reduce the behavior problems. But how can we manage this in a more efficient way? So in the past years, we have considered try to implementing a whole of society approach might be a good or might be a practical approach in the society from a public health perspective. So here's the scheme that we try to describe this approach. We put the people living with dementia in the center of the core of this circle. For this population, we understand that there's no cure for dementia, but we still can do something to maintain their function, to preserve their dignity, and try to make them to live in more meaningful in the society. But where do they live? How do they live? What people? How do they live? And who do they live with? We understand that most of the people living with dementia in China live with their family or live at home. So it seems that we have to build the family environment to be more supportive. So supporting the family might be one of the solutions to provide optimal care. So that's why about 20 years ago, I established the first Chinese dementia caregiver support group. At the beginning, the group consists of the participants to the group are all family members of people living with dementia. But nowadays, more home-based caregivers join this group. But still, we can see that a lot of participants are family members. But in order to provide support for the families, the efforts from us, like physicians or registered nurses, are not enough because family members cannot always get access to the hospital service. So they need to get access at their neighborhood. That is where the community supports. So we think that from the whole of society approach perspective, the community should be built to maximize their function. For example, the community might not only be responsible for the community management, they also need to try to be more proficient in providing support. For example, some communities can help to build organizations or try to introduce non-government organizations in the community to provide support, like social worker centers, or try to build the caregiver support groups in this community. And in that way, that can build more collaboration between communities and other professional services. In order to make the community to be motivated to providing care, then we need to make our society to be more collaborative. That's why we think that this is the function that our policy can take an important role. So if our policy can put dementia as one of the priorities in the society and try to make documents or try to build a strategic plan to improve the awareness of the society, that can build more collaboration between different sectors. And also different sectors can put their efforts together in a collective effort to support the communities. And the community can have more like multi-channel resources. Some sectors provide money, some sectors provide technique, some sectors can provide human resources. So in that way, we can make this approach, whole of society approach, to be more flexible, and the people living with dementia will feel more friendly in this environment. So within such a perspective, we try to bring the concept of providing continuous dementia care in the society. So in this continuum, we can split that into 4 stages. Before people are diagnosed with dementia, they need to be screened so that people at risk can be identified earlier or in a timely manner. So risk assessment and high-risk population screening is an important part for us to improve the rate of diagnosis. As ADI's World Alzheimer's Report has mentioned that there is a great gap of diagnosis in undeveloped areas and also in unrepresented population. So try to improve the rate of screening and try to identify high-risk population might be an important step for timely diagnosis. Once the person is suspected of dementia, where they can support it, of course, memory clinics is an important area, important setting that people can be referred. So we should teach the specialists in memory clinics to try to provide scientific assessment and try to provide a timely diagnosis. We cannot say that dementia is not, diagnosing dementia is not meaningful, it's not beneficial. We have to educate physicians in different levels to understand that timely diagnosis can be beneficial for the people living with dementia, because they will have more opportunity to get access to good support. And also the family caregivers or informal caregivers can be supported by more evidence-based approach. So once the people is diagnosed, they should definitely be supported with pharmacological and non-pharmacological intervention. So currently, more and more non-pharmacological intervention has been developed. And also we understand worldwide that there are many studies are trying to explore the evidence of these non-pharmacological interventions. So in order to help people receiving good care, we have to provide the continuous and post-diagnostic support. So not only medications, but also non-pharmacological intervention. So in this way, we have to provide very good or high standard of psychosocial intervention. For example, how to manage the behaviors of people living with dementia, how to help them to build their cognitive function, like how we can disseminate cognitive stimulation therapy during this population. So in addition to the support for people living with dementia, we also have to support the family. So family caregiver support is an important part in during this journey of dementia care. So in the past years, in the past decade, we have accumulated a lot of experiences, how we can support the families, either in a group or individually. So I think that in the past practical years has stimulated us to try to improve all these services, or try to bring all the services to the people living with dementia, no matter where they live. So as I mentioned that a lot of people living with dementia live at home. So definitely we have to try to bring more information, bring more services into the community. That's why we created the program named as Healthy Memory in Community. We know that in the hospital, we build memory clinics, but in the community, sometimes we have to use a more positive meaning or more positive name. So that's why we named it as Healthy Memory in Community. But also we have another type of services that's when people eventually have to be institutionalized, we have to provide support for residential care. So I'm going to talk these two parts of services. First, let's talk about the Healthy Memory in Community program. As I mentioned that in order to provide sufficient high efficient services for people living with dementia in community, we have to try to bring more resources together. For example, currently in China, community health centers have been built quite in many areas. So people always can always get access to community health services in their neighborhood. And our government has introduced different types of public health services package. For example, people having hypertension, diabetes, or obesity, they can get support in the community health services freely. They can receive full checkup in the community every year, and that's free. They can also receive one free laboratory test to monitor this, the indicators or physical indicators. And also for people aged 60 and above, they can receive annual physical checkup at no cost by themselves. So in this way, we consider that community health centers might play an important role to provide health education and provide cognitive screening in their routine practice. And also during annual physical checkup, routine lab tests can help us to screen some of the other potential risks for dementia. For example, we can screen for physical diseases, severe like hepatic dysfunction, severe renal dysfunction. But we also can help to identify the difficulties in metabolism deficit. For example, people can get screening for thyroid diseases, and people can be screened for their nutrition status. So this can be integrated with the community public health package services. But also when people are screened as suspected positive, they need to be referred for specialist care, for comprehensive assessment for cognitive function, for behavior evaluation, and the functional assessment. And the specialists can also help to make a diagnosis based on the evidence of all the test results, and also based on their interviews with the people who are suspected of dementia. In that way, specialists can make a timely diagnosis and help them to develop a person-centered care plan, including medication and non-pharmacological intervention, and also provide how we can support the family. So once the people are referred back to the community, their family members can be supported in the community, and also the community health centers can help to do follow-up visits, because this can be integrated with their usual public health examination. So this within this model, we call it as a specialist and community collaborative management model. So in the past years, in big cities like Beijing, Shanghai, and some of the provincial capital cities, such model has been tested, and we can see that there's benefit. The rate of diagnosis has been improved, and the literacy has been improved as well. So I'm going to use this example in Beijing that we have tested as an example to introduce how healthy memory in community can be beneficial for the people living with dementia, and also for the whole society for health promotion, for eventually risk reduction. In the year of during the year of 2015 to 2018, we implemented this program in some Beijing communities. And the ultimate goal for us is trying to improve the prevention of dementia in the community. I mean, try to use the healthy behavior approach. And also we have to promote the early diagnosis, early detection of dementia, and to improve the continuous care for people living with dementia. So in this program, there are 4 key components, including community training for primary care physicians and the social workers. And also through the education for this community-based staff, they help us to educate the public population and then raise the public awareness in their community. And also once the community-based staff have been trained, they can administer screening test, brief screening test in their routine practice. And then that can help the people to be screened. And also if somebody is suspected of positive, they will be referred for comprehensive assessment and for diagnosis. And once the people is diagnosed with mild cognitive impairment and dementia, they will be referred for stepped care. I'm going to introduce that in the future. So I will show you how our practice is and what is the outcome. After we train the community health workers, we monitored their level of knowledge and skills. We found that all their knowledge and skills could be improved dramatically. And interestingly, this improvement in knowledge and skills can be transferred into their practice. So the rate of screening has been improved. Before the program was implemented in the communities, there was no practice at all to screen the people with the brief cognitive screening instrument. But after the training, after all these physicians has been trained extensively, the rate of screening could improve to 30%. We definitely know that this is not that excellent, but it is much better than zero. So because there's a huge gap in the society for timely diagnosis. So once the screening rate can be improved up to 30%, that can help a lot of people to be screened at early stage and to be intervened in at early stage. So after all this community workers receive training, they get more knowledge, and they were also trained how to deliver public education to the audience in their community. And we monitored the level of literacy of the participants in the health educational events. We found that the literacy of dementia has been improved from 47% to 77%. So this is a good indicator that through education, the awareness and the literacy of dementia could be improved. And also about 60% of the participants to the educational event, sessions consented to be screened. That is also a promising indicator that after screening, after public awareness campaigns, that can help us to improve the rate of screening and improve the opportunity for optimal care. And for those people who are diagnosed with mild cognitive impairment, at that time, there was no cure of mild cognitive impairment. There was no medication. So we tried to introduce a type of cognitive training in the community. So community volunteers run the session as a workshop. The old adults can join this workshop and they can train themselves through the computerized program. So everybody was given a laptop, given a tablet, and then they can choose what activities they should be trained. So all these participants were assessed with a comprehensive neuropsychological assessment, and their cognitive function guided us to develop an individualized training program. So everybody received their own training curriculum, and then the volunteers were trained and helped them and guided them how to get access to each exercise they need to be trained. So after 6 months training, we found that their processing speed could be improved. Some of the indicators of executive function also can be improved. And our research also indicates that their neural network, we did neuroimaging studies. We found that part of the neural network indicators can be reshaped. So that gave us a promising results that actually mild cognitive impairment can benefit from cognitive training. And also the exercise, computerized exercise, can be easily implemented in community. And for those people who are diagnosed with different levels of dementia, some communities are trained to provide a group exercise, and also they can deliver this in the community centers. That is the common form currently in China. It's called like community embedded senior center. So old adults can join their activities, and then in that way that can help them to maintain their awareness. Although we understand that cognitive function might not be easily to be improved, but their mental health status, their mental well-being can be improved. So life satisfaction could be improved. In that way, we also try to introduce the caregiver support group into the community. As Professor Vigis just mentioned that we established first Chinese dementia caregiver support group in our hospital, but we know that it is not so easy for everybody to join our hospitalized caregiver support. So we try after we make our caregiver support group to be more manualized, we eventually developed a toolkit to run or organize the dementia caregiver support in the community. So currently, the trainees can now run the community-based caregiver support in the communities. So most of the trainees are community nurses or social workers. That is easier. So based on this work, we have published a book series on healthy memory in community that includes the essentials of dementia and the basic screening skills. And also we developed 2 workbooks that to coach dementia caregiver support. And also we developed a diary for caregivers. They can document the activities and experiences during their daily activities. Nowadays, we also promote memory clinics network to build more community liaison. So in China, more than 200 memory clinics have been established. Although that is not enough, but it can help us to improve the care and try to reach the people living in different areas. And we understand that in some provinces, like Tianjin, Zhejiang province, they also establish memory clinic networks that within their provision level, people can get access to different cities. They develop memory clinics, and people don't need to travel for a long way to the provincial capital city. They can just seek care in their local area. So this is a good indicator for to help us to improve the coverage of memory clinical service. So we understand that with this type of work, we can definitely promote a lot of dementia care in community. But we also could not ignore the need of the people living in residential care. So in the past years, we tried to, we spent many years to explore the community-based care, but we understand that there's also a strong demand for residential care. So about 2 years ago, we started to collaborate with nursing homes, how to develop a standard care approach for people living with moderate and severe stage in nursing facilities. So a couple of years ago, we developed a set of quality indicators of psychosocial intervention for persons living with dementia, because we found that during the educational program, there have been a lot of educational sessions on how to provide daily care, how to provide nutrition assessment and support for people living in old age. But shortage of educational program on how to provide psychosocial intervention for nursing homes and like residential care, especially for people living with dementia. So that's why several years ago, we developed expert consensus quality indicators. So within this system, we identified 5 domains, including providing a comprehensive assessment for people living with dementia and their carers, communication about the diagnosis and the care plan, and also developing individualized care for a psychosocial care and how to implement the psychosocial plan. And also another 2 domains include provider support intervention for primary carers and how to organize the multidisciplinary team. So within these indicators that guided us how to provide a good person-centered care in nursing homes. So also we collaborated with Professor Norman Sartorius and his team to validate an instrument named as International Dementia for the assessment and staging of care for dementia. Why we validated this instrument? Because the other scales like CDR, they usually stage dementia according to cognitive function, but the need of care has not been paid much attention. But this instrument is briefly mentioned as ideal. The ideal instrument actually put the domain of need for care in as one of major. So we think that this might be more applicable for nursing care, especially for facility care. We validated this in practice and found that it's easily to be used and accepted for nursing homes. So we introduced this instrument for our protocol, and we developed a mini program that can be used on smartphone. So the carers, nursing staff can be trained to use this mini program to do assessment for the old adults living in their facility for people living with dementia, including their physical condition assessment, nutrition, pain assessment, and also like behavior problems evaluation. And in that way, we can identify the target problem during care. And then as long as the target problem is identified, the whole team, including our geriatric psychiatrist, registered nurse, nursing staff, the manager of the nursing facility, and also the carers in the facility, we discussed together and then formulate an individualized care plan. So each person has his own plan to be cared. And then we developed a form that the carers can document how they implement this care plan. So every week we reviewed the implementation process and try to dynamically monitor this program and monitor and try to improve the care. For example, sometimes we need to calibrate the plan, try to monitor the progress in the care. So in this circle that can help us to try to meet the needs of the person and provide the care, just try to meeting his needs. So this program, this is the interface of the program. It has been copyrighted and people can use it freely. So within this program, we also insert some of the algorithm that can help the staff to identify what is key problems after the assessment. We also embed some of the expert consensus in the program. So the staff can just look for information to identify what is the priority of the technology of approach to support people living with dementia in his or her care. And that can help them to try to take the first step easily. So once we review the whole case, we can have further discussion and they can calibrate and modify the plan. So these are some of the pictures that were taken in nursing homes. People can, they receive cognitive training, they do the planting, they do cognitive exercise with like play cards, and they do psychomotor training. And also last year we developed a program called Music, Exercise, and Cognitive Task Hybrid Program. So our volunteers train them how to play this exercise, and they were happy during this training. So in the last few minutes, I will mention that based on these activities, we have see a lot of promise how we can improve our care for people living with dementia. So actually, in the past decade, our government has issued different type of documents on mental health, aging, elder care services. For sometimes dementia care is included in the mental health documents. Sometimes dementia is included in the aging care, aging services, and also they can be specifically included in elder care services. But one of the greatest progress was the National Dementia Strategic Plan released last year. I'm sure that some of our audience have known this. Last year, our government released this Dementia Strategic Plan. It aimed to create a dementia-friendly society, increase the public awareness of dementia in the society, or try to make the whole population understand dementia quite well. And also, it encouraged us to build a multidisciplinary dementia care network and to support capacity building for staff. And the ultimate goal is trying to provide integrated care for people living with dementia and also promote the risk reduction and prevention of dementia. We understand that this is an aggressive goal, but based on some of the activities I just mentioned, we have seen the promise. As long as all these activities can be implemented in more areas, I'm sure that people can benefit from such activity. So within this plan, the activities, they include 6 key activities. On the left corner, there are 3 activities that we need to implement in the community. For example, health education and promotion, cognitive screening, and providing individualized care and prevention. But on the right column, all these 3 activities are the basis for us to providing quality of care. That includes building the multidisciplinary teams. That means health professionals, social workers, psychological service providers, volunteers, community staff should be working together. And also we need to improve the service capacity. That means we have to make the people working in different areas to be well trained. In that way, there will be a wider coverage of service. Otherwise, if we only train the people in big cities, we can only have limited coverage of care. So within this plan, it helps us to try to build more confidence to improve service capacity. And also it encourages us to create a data sharing platform. I'm going to show some of the activities that we try to improve the capacity building. In the past years, we try to develop some of the training program to train carers, and also trying to exchange different activities or experiences in nursing homes, community centers. We also invite international experts to join our dementia care forum. DY has joined us to our first dementia care forum, and professor from the Netherlands, from UK also joined us. And also 2 years ago, Professor Gloria Wang also attended our dementia care forum. She trained us about cognitive stimulation training in our session. We also train a lot of community staff and social workers how to run the community-based dementia care support group. And in this way, that provided a service for us. That's why currently we feel more confident that eventually the community-based support group can be implemented in more areas. We also developed some of the learning resources. We collaborated with WHO because our hospital is also a collaboration center for mental health training and research. So we translated the iSupport program into Chinese and built a server in China. So in the very near future, this program will be open to the whole public at free cost. And currently, we are also collaborating with Australian team to test the effectiveness in the future of the ICE protocol program for family caregivers. We also published several books about how to train the carers for dementia and how we can manage the behaviors like agitation in dementia care support. And also, we know that since the outbreak of COVID-19, we have to move a lot of educational sessions to the online platform. So we recorded a lot of videos, short videos, to train how to manage behavior problems, how to reduce the risk of dementia care, and how to develop the meaningful activities to support people living with dementia. So all these materials will be available online. And I mentioned that we also developed the music, exercise, and cognitive hybrid activities. And the video, the demo video could be reached on YouTube. We have already uploaded to the YouTube, Chinese Youku, and also the Bilibili. So people can, that's Chinese YouTube. So you can find the video about the MECR exercise. And also last year, we collaborated with the National Health Commission. We developed an aging cognitive care toolkit. So the family members can get all these resources within this toolkit, and then that can give them a lot of instruction. So this toolkit will be also published officially by Beijing University Medical Press. So currently the publisher is working on that. So in conclusion, I would say that the continuity of dementia care is an important concept. It has a wide coverage, including timely diagnosis, optimal care, and also risk reduction. And I would say that community-based care and residential care are complementary. Although we put a lot of exercise in community, but we still need to pay much attention for residential care and provide quality care for people living in nursing facilities, although they live in moderate and severe stage. And with the implementation of our dementia strategic plan, we definitely can have a more wide coverage of dementia care. And also currently we are developing the protocol to evaluate the policy. And this year, as far as I know, that the world indicator is trying to promote the dementia awareness up to 60% in the society, and also increase the screening rate to 60%. And next year, they need to be increased up to 80%. So that's my talk, and I hope that this information will be informative, and I hope that we can have more discussion, especially on the topic of how to evaluate of the impact of the policy. Thank you very much.
Thank you so much, Professor Wang. And I must say, an extremely articulate and beautifully presented lecture, which gives us a very clear picture of the work you've done and this work that's ongoing in Beijing. And of course, our focus here is on the Greater Bay Area, which I'd like to draw your attention to, if I can, with some questions. If you would be kind enough to answer those, we would be very grateful. Can you give us a little bit of information about how you see challenges to cognitive screening throughout China? In other words, we know there's a variation in many aspects of risk factors throughout China. Perhaps if you could just focus on the Greater Bay Area, maybe you could give us your suggestions on how to improve cognitive screening within our region.
Thank you very much, Professor Vicky. It's my great honor to join this, as I mentioned. And the question is important that about the screening. I think think that each time when I talk about how to provide optimal care for people living with dementia, this is a question that we have to address. Of course, there's no universal screening test for the people living in with different areas. But as far as the evidence show, like mini-cog, cog state, 88 or CSID, they definitely can be applicable to more educated education. But as you mentioned that in Bay Area, probably some of the old adults, they do not receive quite a lot of education. Also, they might speak their own language, dialect. They might not get access to the simplified Chinese version. I mean, different areas, we have different language customs. So my perspective, it might be different. I would like to answer this in a different angle. In China, one of the greatest challenges is that there's a huge gap of diagnosis. So a lot of people living with dementia has not been diagnosed, no matter what stage. So it's different from developed country. Probably in developed countries, people are trying to advocate for early diagnosis. But I would say that in our situation, of course, early diagnosis is important, but still a lot of people living in moderate, severe stage, they have not been identified yet. So screening for those people actually are not too difficult. We can use like functional assessment, a brief interview with the family members for screening, as long as we can talk about this topic. But for early stage, definitely that's a great challenge. But I would say that if we can make every effort to minimize the gap, although we might have some, we might be compromised for early diagnosis, but we can find more people who need support. That is one important aspect. But in order for early diagnosis, I understand that in Guangzhou, some of the experts, they are trying to develop the Cantonese version for cognitive screening. And we also put some efforts on this aspect. In the past 3 years, Professor Yu Xin in our hospital, he's also the director for WHO Collaboration Center. He leads a project to build the norms of several cognitive assessment instruments. I understand that he has collected from data from different areas. So probably based on his findings, that can provide more evidence for screening in different areas. He, in his sample, people without any education were also included. So probably in next year, when he published his findings, we can have more resources for early detection.
Thank you so much. If you don't mind, I'll just intrude with my own experience in Beijing, as I mentioned, from the early 90s, where a focus for my work then with colleagues such as Professor Yin Wang was dyslexia. At that time, the diagnosis of dyslexia was virtually unheard of in China. And so exactly your point, yes, by then there were many ways to detect dyslexia in Indo-European languages that we could have applied in Beijing at that time. But in fact, the bigger problem was simply the recognition at a very, very fundamental level of what it might mean for a child who has perfectly adequate cognitive skills and often very good educational attainment, but can't read and write or has failure in learning characters. So, you know, this is, I agree, a very basic level at which you have to enter in nosology of any kind of medical concern. So I understand exactly your point, and I thank you for making that point. It's a very important one. Of course, outside of Greater China, people want to throw their tests and their ideas and their must do this, must do that, but actually there's a bigger, more profound issue that needs to be addressed first. Thank you. Now we have another question from the floor, which I will read out. You may be able to see it actually, Professor Wang. It's from Cheng Shi. In May, the China Association for the Aged issued a report on dementia care for older people. It's estimated there are about 15.07 million persons aged 60 and over living with dementia in mainland China. Do you know what screening tool they actually used?
Thank you, Dr. Shi, asked this question. I need to go back to that paper probably later because I was not involved in that study. So if that is not included in the paper, probably I need to find some opportunity to ask the authors about their instrument. I'm sorry that I cannot provide you accurate response now, but
yes, we're trying to let the audience ask questions, and thank you for your patience. I guess we should probably, I think you might agree with me in saying that, you know, there are hundreds of potential screening tests and there's no one perfect test. I think that's the point of your presentation, which is to show quite clearly that different cultural groups, different linguistic backgrounds require sensitivity, and then we're not working towards one single perfect screening instrument. So any questions that have that assumption are flawed, actually. So thank you very much for your patience. Let's ask another question though, which is more broader. And I think I'm going to be able to give some perspective here if you could address this question in your own experience, which is, what about the issue of digital exclusion amongst seniors in Greater China? So we notice from the outside the incredible embrace of digital technology in China from the young, but also in the elderly. What issues are there regarding digital exclusion that you see insofar as awareness of dementia at the grassroots?
Yeah, thank you for this question. I mean, I'm not a digital expert, but I would like to answer this based on my experiences working with the older adults. Each time when we talk about digital exclusion, of course, we know that those old people, they are not experienced in using this digital technology. They might feel difficulty in like getting access to the services that need a lot of this digital technology. I would like to address this in from two aspects. One aspect is that they are not that difficult to be educated. So sometimes when because we have developed some of the digital-based digital tech support. So when the family members come to our clinics, even older spouse of the people living with dementia, we ask them, do you use mobile phone? They said, yes, we have. That's a smartphone. So we train them step by step how to get access to the online cognitive training, how to scan the barcode to get access to some of the educational videos. They can use that. It's not that difficult, but as long as we can make these steps easier, so it seems that it's not that sophisticated, that's not quite modernized, but easy steps will be accepted. But on the other way, although our younger generation are keen on this virtual platform, but old adults are more eager to join face-to-face interaction. Virtual platform can be efficient, but it's not that friendly because facing the machine might not have a good temperature. I mean, it's not so warm as we interact with the person face to face. So here I said some examples. Last year, during COVID-19 quarantine policy, we have to move our caregiver support to the online educational program. We increased the frequency of the program because before the COVID-19, we only run the program once monthly. So like we run monthly program. But during COVID-19, we understand the family caregivers have a strong distress. So we increase the frequency. We run the support every other week. But still, a lot of them were eager to join the face-to-face meeting. So this year, in May, we launched the first face-to-face caregiver support after COVID-19. That was warmly welcomed by the family caregivers. So my perspective is that digital technology is inevitable advance. We need to try to translate that into practice care, the care practice. But we still need to consider the face-to-face support is more friendly. We need to bring our heart, bring our temperature, bring our support to the people as long as they can feel this empathy.
Thank you so much. We're running out of time, unfortunately. It would be wonderful to speak further with you, and it's such a privilege to have you present today. But Dr. Carteri has a question that she would like to put to you before we move on. Go ahead, Teresa.
It's more a comment than a question. So first of all, thank you for your outstanding talk. We are very honored. It was a very inspiring talk. Thank you very much. But about this topic, you were talking about digital inclusion and this feeling that doesn't feel so close. I think, as you mentioned, I am impressed by the programs you have developed and the long-term goals being implemented. It's so efficient. It's very impressive. But I think about this point of digital inclusion, it's very good to invest on that because in the big centers, sometimes the elderly cannot go. It's different maybe from the reality of the GBA, but from another point of view, maybe this can be the only way to make this accessible for people. So I think it's a very important point that you made, and that is possible to teach. I have also experience of cognitive training with elderly, and it's really possible, feasible, and should be an area of implementing services because we can reach more people that maybe cannot go to our place. Thank you so much.
Thank you, Dr. Catherine. Yeah.
Well, unfortunately, we have to finish now, but please do, if you can, I know you're a very, very busy person, but Professor Claire will join us in an hour and a half for Q&A. And I think you may find some shared experience of value. I know she would enjoy hearing more from you. So if possible, could you please come back? But of course, if not, we thank you very much again and grateful to your presentation. Thank you.
Yeah, thank you. I will stay in the session and trying to get more information from the talk. Thank you very much.
Okay, thank you.